Hello, everyone. My name is Dr. Marianne Gausche-Hill. I'm the medical director of the Los Angeles County Emergency Medical Services Agency, professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine. I'm also clinical faculty at Harbor-UCLA Medical Center in the departments of emergency medicine and pediatrics, and senior consultant for the EMS for Children Innovation and Improvement Center. And today I'm here to talk to you about a topic that we've all had to face with the increase in behavioral health conditions that we're seeing, especially in children. And this is funded through HRSA HHS, and you see the award there. And I need to state that the contents are those of myself and do not necessarily represent the official view of nor endorsement of any of the federal agencies, including HRSA, HHS, or the US government. So thanks. Here we go. So we're going to start out with some of the resources that are out there. This is a great algorithm that can be incredibly helpful, along with additional resources that are at the site. And we'll have a QR code at the end so you can click onto it. But this is by the EIIC and TREC, which is Translating Emergency Knowledge for Kids. As you can see, the algorithm starts out in recognition of agitation, some of the initial strategies like de-escalation and calming, and then it moves to what is your assessment? What do you think is going on? And potential pharmacologic interventions, if indeed those are necessary. I'd like to present some cases to you. And as I present the case, I would like you to really think about what you would do for each of those. And then I had the unique opportunity to work with some amazing emergency psychiatrists, both an adult emergency psychiatrist and a pediatric emergency psychiatrist. And we actually created the 4 cases based on our own experience and then talked through each of those. And I'm going to give you what they thought. So let's run through the cases and I'll bring up the scenario again. This is an 8-year-old girl with suicidal ideation or intent, and she has oppositional behavior and screaming and trying to escape the ED. And this is a kid who ultimately required a lot of people to interact with her. And so we'll talk more about that later. A 10-year-old autistic male who's violent with staff. A 16-year-old adolescent female with substance abuse disorder, psychosis, and defiant behavior requires sedation for agitation. So you could not calm her. And again, you might have to use both physical restraint and pharmacologic intervention. And then finally, a 20-year-old male schizophrenic had a very difficult time focusing. He's agitated and he's overall cooperative with staff, although he's very disjointed and again, very tangential, not only in his thinking, but in his behavior. So what do we do? Well, let's go through each one again. With in mind, as I stated before, what do the experts say? So here's that 8-year-old girl with oppositional behavior. She's screaming in the ED and trying to escape. So what would our strategy be? I'd say verbal de-escalation. I would bargain with her. You know, we'll let you talk to your mom if you can remain calm, as an example. Appease what is going on. I'm hungry. Nobody's giving me anything, and they're screaming. All right, I'll bring you something to eat. Oral meds first, if you're able to do so. And then we decided if indeed she continues to scream and try to escape, that we would use diphenhydramine and haloperidol. The antipsychotics actually work really well here. And especially if there's any concern, you may, again, have to use physical restraint with her. And in actuality, this is a real case that I had. And I said, she ultimately took a lot of team members. I think not only did the physical restraint team come in, all right, but there were 5 of them and then 3 other additional staff just to be able to give her the intramuscular meds and try to get her calm. And she ultimately was calm and got admitted to the hospital. All right, here's a 10-year-old autistic male who's violent with staff. So meaning, he's angry, he looks like he's going to be violent, he may hit staff. So I think a strategy is limit setting. First of all, you do not do that. That's not what we do here. You don't want to hurt yourself or others, and really utilize the parents very much involved with trying to de-escalate them. Decrease stimulation in the room, I mentioned earlier, and I think that's very important. Calm environment. And then what meds could be given? I think the olanzapine works really great, and risperidone PO both can be. They have a liquid formulation of risperidone and then olanzapine, and you can give the ODT. And they have different sizes of the ODT. So I think a 10-year-old you could use easily 2.5 to 5 milligrams. And then the next one is a 16-year-old female, substance abuse disorder, psychosis, defiant behavior. And really, there's no way that she's calming down without some type of pharmacologic intervention. So benzos and antipsychotics can be used together depending on whether she's acutely intoxicated. If she's acutely intoxicated with something, you need to be careful. Now, if it's a sympathomimetic like cocaine or methamphetamine, then giving a benzo is a great idea, as well as an antipsychotic. But benzos really are the treatment for those toxidromes, okay? But if it's alcohol, I would stay away from a benzo, and we often have to use, unless it's alcohol withdrawal or benzo withdrawal, then we would use benzo. Otherwise, we would just use antipsychotics. And that's what myself and our experts decided together. So our last case is a 20-year-old male with schizophrenia who's agitated, but overall cooperative with staff. So some of the strategies here is just, try to redirect, place him back on his regular meds. Olanzapine is a great bridge. I love it. And his age, you give him 10 milligrams of the oral disintegrating tab. It's easy to do. And it takes about 15 minutes, but they typically get pretty mellow in that time. And it's pretty long lasting. It can last up to 30 hours. So that might give some time to get the evaluation completed, make a decision on what other meds you want to start. And risperidone also could be used. So what have we learned today? I think the bottom line is that you always want to consider the patient and staff safety. I mean, that's paramount. You try to begin with this de-escalation first, verbal de-escalation, and then use of non-pharmacologic methods for de-escalation, calming methods, environmental methods. All of those are very helpful. Utilize the parents and caregivers about what works, and you would utilize them in their therapy for certain patients like developmental delay or autism. You want to meet their physical needs and their comfort. Those can also be triggers and cause a patient to escalate. And then the key thing here is, and I'm hoping we helped you do this today, is develop a toolbox of medications, both orally, IM and IV too, but especially PO and IM are going to be the ones that are most used in these settings. Here's a QR code that's going to link you to the resources that you need, that EIIC algorithm, which I think is really helpful, and the medication table. I personally want to acknowledge Drs. Patrick Kelly and Eric Chung for their assistance with me as I developed this talk for you. And obviously the wonderful expertise of the EMS for Children Innovation Improvement Center and TRAC for them really coming together to collaborate on these resources that will help you take better care of your patients. Thanks for listening. You can email me at mgausche-hill@dhs.lacounty.gov or on Twitter at mgausche-hill. Thanks so much.